The second scientific session is the guidelines on edema management. And to speak on this particular session, I would like to welcome Dr. Guruprasad Bhattacharya. He is a cardio-diabetes physician from Howrah with more than 23 years of experience. He is attached to Narayana Super Speciality Hospital and other clinics. He is the founder member and assistant secretary of Howrah Town Diabetes Study Society. He has attended several national and international conferences and presented in several CMAs. I welcome you, sir. To chair this particular session, I would like to invite a very senior consultant physician, Dr. Shukanti Bhattacharya. He is also the professor and head of medical physiology, Eye Care Institute of Medical Science and Research. He has several publications and also authored several book chapters. I welcome the chairperson and I request you to introduce the speaker.
Good morning, everybody. Now, we are going to witness a very interesting session on edema, particularly management of edema in our perspective. And whole of this topic will revolve around the Starling's hypothesis of capillary permeability at various dimensions. So, let's have a robust medical journey through next few minutes.
Thank you, Chairperson. Good morning, everybody present in this hall. On this second day of Howrah Town Diabetes Study Society's 9th conference, my talk will be on a symptom, that is edema. You know, every alternate day, maybe every day, we physicians see patients with pedal edema, maybe sacral edema, maybe facial puffiness. And it's a very frightening symptom. Patient gets very upset. What is going on? What is going on? I have to get rid of the edema. And such a topic should need a clear-cut assessment, clear-cut appreciation of the problem so that the disease can be identified and treated accordingly. In this respect, Indian Association of Physicians of India, with a collaboration with Cipla Laboratories Limited, in 2023, made a consensus statement involving various reputed physicians and their opinions and experiences and multiple citations and textbook writings. And this is the edema guidelines, that is the consensus statement, which I will be saying in the subsequent 20 minutes. And as you all know, it's more prevalent in patients aged more than 50 years, and also female gender, diabetes mellitus, hypertension, obesity, etc. are predisposing factors to development of edema. And we know as physicians, heart, kidney, liver, etc. are at fault, could be at fault. But if left untreated, edema itself may predispose to patients to infection, ulceration of the skin, cardiorenal syndrome leading to fatality, and in certain etiologies even increasing the risk of mortality. And this is the edema. Obviously, this is pedal edema. And I am talking on the Indian expert consensus on diagnosis and management of edema. Now, you know that interstitium holds several liters of fluid, becoming clinically apparent only there is 3 kg increase in the fluid. And the patient's weight may rise by almost 10% if the patient is coming to you 60 kg, and if you treat her or his edema, and the patient may lose 6 kg, and that's not anything to concern because there is 10% weight increase. And this is the most complicated slide. This is the pathophysiology of and common causes of edema. On the left-hand side, there is arterial end, and right-hand side, there is venous end, and in between is the capillary bed. And these are the causes, like increased capillary hydrostatic pressure, which will drive the fluid from the intravascular site to the interstitium, like venous obstruction, like venous thrombosis, hepatic cirrhosis, leading to stiff liver. the fluid, there is obstruction to venous flow and arterial flow, heart failure, constrictive pericarditis, restrictive cardiomyopathy, renal failure, pregnancy, etc. Effective intravascular volume depletion, that means where will the volume go? The volume will go to the interstitium. It decreased plasma oncotic pressure, like malabsorption, nephrotic syndrome, liver failure, malnutrition, and there could be also decreased interstitial hydrostatic pressure. Decreased interstitial hydrostatic pressure means the intra-arterial pressure is high, so the fluid will move outwards. And medications we all face with amlodipine and its side effect causing parietal edema, which is a common cause of withdrawal of amlodipine, or as we all know. And there is lymphatic obstruction. There could be lymphatic obstruction in our Asian country like India. Filariasis is the commonest cause of lymphatic obstruction. There could be malignancy involving lymph nodes leading to obstruction. There could be surgery where the lymph nodes are removed and lymphatic drainage is impaired. But I will say only 5 points that could lead to development of edema from this pathophysiological slide. There is an increase in intracapillary hydrostatic pressure, already mentioned, inadequate lymphatic drainage, reductions in the oncotic pressure of the plasma. So the plasma cannot hold the fluid anymore, and the fluid will go to the interstitium. Damage to the capillary endothelial barrier, and this is commonly caused by some oncology-used drugs. And increase in oncotic pressure of the interstitial space. This is also, in many cases, drug-induced. And in the pathophysiology of the development of edema, there are only 3 factors which we have all learned in our first MBBS days. The 3 factors are sympathetic nervous system stimulation, renin-angiotensin-aldosterone system axis activation, and posterior pituitary play like arginine vasopressin activation. Arginine vasopressin will hold on the fluid to cause edema. And these are the causes of localized edema and generalized edema. Localized edema management is very local, and it involves mostly physical therapies. And the causes are lymphedema, lipedema. Lipedema is excess deposition of lipids in the dorsum of the feet. And you can differentiate lipedema from edema. There will be no edema in the shin of bone, or there will be no sacral edema or paphiface. There will be deposition of lipids in the dorsum of the feet only. Venous incompetence, deep vein thrombosis, that is the most dreaded one. And dermatitis, cellulitis, etc. Cellulitis could be infective, acute infective could be due to some eczematous process as well. And there is generalized edema. These listings are a bit arbitrary, but just to mention mixed edema, that is very much untreated florid hypothyroidism, heart failure. Dr. Pandey has just talked on the very complicated aspects of the heart failure. That is, we are not meeting the targets. But heart failure commonly is one of the commonest causes of edema. Constrictive pericarditis and restrictive cardiomyopathy is also some to add on to the list. Pulmonary edema, that is a consequence of heart failure. Cor pulmonale we see in the asthmatic or COPD patients, long-standing. Hepatic cirrhosis, nephrotic syndrome, acute renal failure, end-stage renal disease, nutritional deficiency. Nutritional deficiency is mostly seen in the famine-affected areas where eating is restricted. Nowadays, in our practice, we see much less in the nutritional deficiency-induced edema. That is basically hypoproteinemia induced and obesity-related. You know, obese people, due to some, maybe due to some unknown pathophysiological reasons, can develop edema. But this edema is usually of low grade, and edema could be resolved as the patient takes rest and gets up in the morning. Pregnancy, we all know, pregnancy is a hemodynamic excess that is leading to RAS system activation and development of edema. Premenstrual disorders. Premenstrual disorders, it usually occurs in the preceding week of the menstruation cycle. the lady develops edema. It's an edema, it's a cause of exclusion. You have to exclude other serious diseases. And medications, also there is vasculitis, various types of vasculitis can itself damage endothelium and cause edema. This is the pathophysiological diagram of heart failure induced edema. There is myocardial infarction, whatever, leading to LV function decrease. LV function decrease will lead to decreased cardiac output, and ventricular volume symptoms will be more. This will lead to activation of neurohormonal systems like sympathetic nervous system, I have already told you, RAS system activation, arginine vasopressin activation, etc., and endothelin 1 activation. This will lead to hypoperfusion and hypofiltration of the kidneys. And if the kidney is hypoperfused, kidney senses it as an alarming condition. So that will cause tubular sodium reabsorption and hyporesponsiveness to NPs, which will lead to fluid accumulation and sodium accumulation and edema formation. There is also renal vascular congestion, intra-abdominal pressure will be increased, and also systemic vascular resistance, wall stress, blood volume, that is preload, and ventricular filling pressure due to venous congestion, all will be increased in these cases. In nephrotic syndrome, there is two parts. That is one part that is underfill, and another part that is overfill. Where is the overfill? Overfill, it's the defect lies in the kidney itself. So there will be primary sodium and water retention, which will lead to hypervolemia, and hypervolemia will lead to increased capillary hydrostatic pressure, water transudation to the interstitium, and development of edema. And where is the underfill theory? Underfill theory states that in nephrotic syndrome there is huge loss of protein in the urine, so there will be hypoalbuminemia, which will lead to activation of the hormonal axes, which will lead to sodium and water retention and edema. Not only that, as there is hypoalbuminemia in case of nephrotic syndrome, there will be hypovolemia as well. Hypovolemia itself can also increase the RAS system and other systems to cause the development of edema. And now comes the lung or COPD causing edema. There is, you all know, there is carbon dioxide retention and PaO2, that is oxygen, hypooxygenation. These things activates the sympathetic nervous system, catecholamines are increased, endothelins are increased, and these will cause directly on the kidney functions, and there will be disturbances in the hormonal system of the kidney and sodium and water retention and edema formation. Now come to the edema. Edema could be pitting and non-pitting. What is the pitting edema? Edema is the commonest one, where there will be increase in the interstitial fluid volume. But what is the non-pitting edema? Non-pitting edema is the state where there is interstitial mucopolysaccharide-like substances increase. So there will be no pitting in case of non-pitting edema, which is commonly seen in the filariasis. And if a patient comes with edema state, then there will be history taking is of paramount importance, like current illness, like duration of edema, location, where is it unilateral or bilateral, other symptoms like dyspnea, oliguria, fatigue, appetite changes, and pregnancy status, daily weight record, past record of any heart disease, kidney disease, lung disease, etc., history of malignancy, risk factors for deep vein thrombosis also should be evaluated, and any history of drug use. And pitting edema can be graded up to these 5 stages, like no edema, 2 millimeter, 4 millimeter, 6 millimeter, or 8 millimeter depression after pressing on the dorsum of the feet or the scene of the tibia, and that could be graded as 1+, 2+, 3+, and 4+ scale. And Well score, it is a very important score where you will be suspecting the patient of having deep venous thrombosis, like active cancer or cancer treatment, paralysis of any side of any, or recent cast embolization, recently bedridden for 3 days or major surgery within the previous 12 weeks, localized tenderness along the distribution of deep vein territory, entire leg swelling, calf swelling of at least 3 centimeters larger. You have to note that you have to measure the calf girth 10 centimeters below the ischial tibial tuberosity. Pitting edema confined to symptomatic leg only. unilateral collateral superficial venous prominence, previously documented deep vein thrombosis. And if the doctor says that there could be other cause of pitting of that limb edema, that is given -2 score. So the Wells score scoring system -2 to 1 is deep vein thrombosis is unlikely, and 2 to 8 is likely, and also the probability like that. Patient self-evaluation. This chart should be circulated in the display areas, like a patient can himself do that. If the total score is more than equal to 3, there is risk of edema is there. And if the total score is less than equal to 2, there is minimal risk of edema. And the questionnaire is very simple, like age in gender, female sex or male sex, swelling in both legs or not, swelling in legs that accentuates in the evening or not, swelling in the all of the body, swelling on the face during morning, do you have breathing difficulty while lying down or walking, and also the history of heart disease, liver disease, kidney disease, endocrine system, etc. This score is very much effective. As a lay people can use this score to ascertain whether they are having any serious cause of edema or not. Now, Indian screening for recommendation is including a careful history and examination of the mainstays of appropriate diagnosis and subsequent management is clearly stated in the first point. In case of suspicion of DVT, one should risk stratify by the Wells score using the clinically probability Wells score. The edema grading scale can help differentiate between the pitting and non-pitting edema and aid in identifying the etiology of edema, and may consider administering a simple self-evaluation test I have already told you. Investigations. Investigations are clinically related, like in case of cardiac cause, if you suspect there is chest X-ray, echocardiography, ECG, NT-proBNP. Renal disorder should evaluate for
2 minutes more.
urea creatine. I have only 1 minute excess. Albumin, liver function test, APTT, INR, etc. Localized edema are basically to assess the venous system, like venous incompetence, lymphatic obstruction, lymphatic system, dermatology, cellularity, all of the local causes. There's the duplex Doppler, renal Doppler, lymphangio-scintigram could be used in these cases. Diagnostic approach of unilateral edema is very simple, like painless or painful. If the patient is having painful, it involves, if only disease, we should think of inflammatory arthritis. If part of the limb is affected, this could be due to cellulitis. Involve the whole limb, it should be non-pitting or pitting. If there is pitting, Wells score could come into play. It is positive, then it is deep vein thrombosis. If they are not positive, you can rule out. And non-pitting edema, pyelonephritis, etc. And the painless edema is differentiated by acquired or congenital. We know that congenital edema, it is state like limb states like Milroy's disease, anomalous venous connections, and acquired causes of painless edema are lymphatic or vascular. Lymphatic could be post-mastectomy, malignancy-induced, and vessels on the right-hand side, deep vein thrombosis, varicose vein, venous insufficiency comes into the play. And bilateral edema, this is the common, I have already told, edema feet could be JVP raised or idiopathic. If JVP is raised, if it is absent, there is nutritional. If it is present, then cardiac failure. If present only in left limb, it could be think of left ventricular failure. And in case of systemic disorder, it is still my edema of cardiac, renal, or hepatic origin. Obesity, I have told. Pregnancy, I have also told. With puffy face, this is the last slide. Puffy face constipation. With constipation, it should think of hypothyroidism. Sudden onset, you should think of angioneuritic edema. And hypoproteinemia, it could be due to nephrotic syndrome or chronic kidney disease like obstetrics. Recommendations: limb elevation, physiotherapy, compression, combination of limb elevation and compression is more effective. Ice application, salt restriction to the tune of 6 grams per day only. Diuretics are the mainstay of therapy. There could be 3 types of diuretics, like loop diuretics, distal convoluted tubule diuretics like chlorthalidone, hydrochlorothiazide, metolazone, loop diuretics, torsemide and furosemide, bumecranide, cortical collecting tubule diuretics like spironolactone, epinephrine, and sodium channel inhibitors like amiloride and triamterene. These are the doses. I'm not going into the details. You all know about the doses. Edema management differs from local and systemic causes. And systemic causes require salt restriction. Diuretics are the mainstay. Torsemide's pharmacology differs from furosemide in that it is superior. But mortality rate could be the same with the furosemide, but it could be given once daily. That is the advantage. Continuous infusion of loop diuretics like furosemide is more better in reducing rapid reduction of edema, essentially due to heart failure-like things. Short-acting furosemide needs more frequent dosage administration to achieve faster and greater diuresis and to overcome diuretic or overcome diuretic resistance. Increasing the dose or frequency or adding thiazide-like diuretics or potassium-sparing diuretics are effective. Adjust the diuretic dose to avoid the hypokalemia or hyponatremia. And in case of HFrEF and early CKD, SGLT2 inhibitors are very strongly indicated. I'm not going into details, but we may suggest to observe 25th September as a National Edema Awareness Day or Edema Day, so as to spread the knowledge and consensus of edema diagnosis and management to the physicians and the lay people as well. And these are the conflicts of interest. Financial assistance from CIPLA was involved in the management of the edema guidelines. Thank you. I am sorry for being late for 1 minute.
Thank you, Dr. Bhattacharya, for very elaborate discussion on the basic clinical sign, its pathophysiology, its management. And now the session is open for the audience for any question.
Thank you, Dr. Guruprasad, for very nicely explaining all the etiology of edema and how to manage it. One important cause in day-to-day practice is that we should always take drug history, whether patient is taking calcium channel blocker, pioglitazone, or NSAID, especially etoricoxib, is notorious to cause edema. So many a times we find edema, and if we explore drug history, we can find it. Sometimes in dengue patient, when there is capillary leak syndrome, there is ascites, pleural effusion, as well as
acute causal edema.
Acute. As well as sometimes in pancreatitis, there is capillary leak syndrome. So that may lead to edema.
Actually, various drugs are implicated in the development of edema. Antihypertensives, NSAIDs group of drugs, pioglitazone most commonly, and calcium channel blocker, amlodipine is commonly. Anti-cancer drugs can also cause edema.
First of all, I must thank you for your illuminative lecture regarding edema. What is your valuable opinion regarding edema following the use of the gabapentin for many days? Gabapentin.
Actually, the edema of drug-induced falls into the category of drug-induced edema, and pregabalin is more implicated in rather than gabapentin. If the drug implicated is pregabalin, you can switch to gabapentin. It may cause some reduction of edema. And reassurance is the mainstay. If the patient cannot be reassured after your advices, then you have to change the therapy. And it is not harmful.
Thank you, Dr. Guruprasad, for your excellent lecture. I just want comment. From the rural area, the pigeons, they remain in standing position for whole day in the field. They present with edema sometimes, I have seen. You will do all the tests, all are negative. You should suspect venous incompetence.
Yes, and venous Doppler.
When you do the Doppler study, you will find venous incompetence.
Yes. And there is also one entity called gravitational edema. It is simply benign, and it vanishes after taking rest.
Yes.
You have to inquire about the postures of the patient. If the patient gets sitting for hours together, he may be developing edema without any obvious cause, without any disease. You should be advising the patient to get up from the chair every hour and walk for 1 or 2 minutes. You can also advise the heel raise exercises, just elevating the heel 4 to 5 times, just hourly or 2 hourly. That will also cause lessening of edema. But it is an diagnosis of exclusion. You have to exclude other comorbidities, if at all present.
My small questions, that is sometimes that is a tourist
reaching on a slight high altitude, 8 to 10,000 feet altitude, and he complains over telephone that is in the morning I am having the facial edema. That is my first question, and I told that you go on walking, you go on walking as if nothing has happened and it will go away, and that is my. Let's have a discussion over it. And another question: one couple stayed with their son for 3 weeks in Bangalore, and when they came back, they told me that we have lost 2.5 to 3 kilos each, and they are happy that they have lost weight. And no, it is a transient weight. Probably the dry weather of Bangalore has some role to play with it. He will regain the weight another 10 to 15 days. And it happened like that. In 15 days, they regained their weight. And how do you explain all these things, please?
Actually, I am answering the first question. In high altitude, there are two causes of edema. One is pulmonary edema. Pulmonary edema is very potentially fatal complication. The patient should descend as rapidly as possible. The patient should be treated as intensively as possible. And there is a good role of steroid in reducing high altitude pulmonary edema. That is HAP. And another cause of edema, that is facial puffiness. It is cold-induced edema. It's some sort of allergic reaction to cold, and that is very benign. And I will request you to say the second question. What is the second question? In short.
Second question, after staying for near about 3 weeks in Bangalore, they identified that they have lost their weight near about 3 kilos. They were happy that we have lost weight, and they told me that we are very happy that we have lost weight while staying with it.
What happens next?
And it happens next. They regained the weight within the 15 days when they come back.
Sorry, it is possibly behavioral, environmental, diet change, physical activity change. These are all responsible for the weight loss and regain.
If one goes to high altitude without adaptation, there will be hypoxia. Because I personally feel that when I went to Leh Ladakh from Delhi to directly, my oxygen saturation was 85%. And I was breathlessness in walking 10 yards on first day. So hypoxia-induced pulmonary vasoconstriction is there, and that will lead to edema.
Right ventricular failure.
Weight loss, because there is lot of walking in hills. So that may be the reason of weight loss. And one thing about refractory edema, if suppose patient is getting a loop diuretic, patient is getting thiazide or thiazide-like diuretic which are acting on distal convoluted tubule, we may add third drug SGLT2 inhibitor as a diuretic, because it will act on proximal convoluted tubule, loop diuretic on loop, and distal convoluted
yes,
tubule.
you can also mineral receptor antagonists like spironolactone, eplerenone. You can also add amyloid group of drug. You can also add acetazolamide like group of drug. You can also write thiazide or thiazide-like type of drug. 4 drugs you can add according to the clinical need. It will augment it will lessen the diuretic resistance. And diuretic dose may be increased to revert the diuretic resistance. There could be some idiopathic resistance to diuretic. So in those cases, addition of drugs acting differently is recommended.
And in heart failure with edema, if it is not responding, it has well mentioned in literature that we can give 3% saline and then we give diuretic, because there will be dilutional hyponatremia and the diuretic will not act properly. So if you give 3% saline to heart failure patient, it's rather we restrict salt in heart failure patient, but temporarily giving 3% saline along with diuretic, it may work.
I'm enriched with your comment.
Okay.
In your clinical practice, have you encountered any patient complaining of facial edema with the use of clavulanic acid in augmentin-D or clavamixer?
What is it?
Facial edema.
Use of?
Facial edema with the use of clavulanic acid incorporated with amoxicillin. That is, for example,
Okay.
clavamixer.
We are talking of coamoxiclav. developing co-amoxiclav, and,
co-amoxiclav, right.
and patient is developing facial
Dr.
edema.
let me finish.
I have not encountered such case.
Stopping the drug will-
It could be allergic in nature.
Dr. Vatel, let me finish now. So, thank you, the learned audience, for very insightful discussion. And so the take-home message of this session is, all sorts of edema revolves around the Starling's hypothesis of capillary permeability, mostly that pertain to the vascular compartment and leads to the interstitial compartment. In your pulmonary edema or cerebral edema, the interstitial compartment takes upper hand, but in all others, the vascular compartment either increase in the hydrostatic pressure or fall in the oncotic pressure. And if we address the pathophysiology, so we can treat them properly. Thank you all.
Thank you, Speaker, sir. Thank you, Chairperson.